Hi all. So we have certain clinical scenarios to discuss in infectious diseases. Common clinical scenarios that we face day to day in our clinical practices as internal medicine residents or practicing physicians. So we have certain clinical scenarios that we will be discussing. So these are clinical discussion rather than exam point of view discussions. So our first case is a 26-year-old engineering student who presented to the hospital with complaints of fever for 12 days duration. The patient was on tour to the Himalayas when his symptoms started. Fever was low grade with no associated chills or rigors. In the first 2 days of fever, he also had loose stools for 2 days, which subsided without any treatment. So as fever was persisting, he was treated with cefixime 200 milligrams for 3 days and there was no relief of symptoms. He did not have any significant comorbidities. He did not report any addictions. There was no high-risk sexual contact. The patient has been consuming food from the local dabas during his entire journey. So that is how he is presented, fever of 12 weeks. To begin, he had some loose stools as well, no other localizing. On examination, he was conscious and oriented. He was well. His temperature was 101. Heart rate was 80. Her BP was 120/80 and respiratory rate was 14 per minute, which means that the patient is stable. Okay. And there was no lymphadenopathy. The abdomen, there was no palpable liver or spleen. Respiratory system, there was normal vesicular breath sound, there was no added sounds, no crepitations, no wheeze. Cardiovascular system, normal heart sounds, no murmurs. Okay. Then we did the basic investigations. So his total leukocyte count was 8,600. Neutrophil 61%, lymphocyte 30, eosinophil 0. Platelet count 1.51 lakhs, something like a low normal. Hemoglobin is normal. MCV is okay. Hematocrit is okay. ESR is 33. CRP is mildly raised, like 12. Malarial antigen is negative. Bilirubin total 1.1. Bilirubin direct is 0.2. Okay, fine, normal. But you have mild elevation in the transaminase levels. ALT and AST are mildly elevated, 89 and 67. Blood urea is 21. Creatinine is 1.1. So what do we have here? We have a young patient who has been on a long trip to northern India, presenting with complaints of a prolonged fever. So how do you call it as prolonged fever? There is no definition of prolonged fever as such. But again, like the fever lasts more than maybe a week, you can call it as prolonged week. It's not a standard definition, just for the practical purposes. And then he had diarrhea in the presentation, but diarrhea is not there as of now. He just has fever. And on evaluation, like physical examination, we couldn't find much. Except for that, during the fever time also, his heart rate is not much elevated. Something called as relative bradycardia. That may be a clue, may not be a clue. Okay, not very sensitive or specific for any. And then again, investigations, when you come, most of it is normal. The total count is normal. Platelet count is going low normal, and there is mild transaminitis alone. So this is how most patients present to us with prolonged fever. So what all differentials will you keep? Before you go, the X-ray is also provided. So look at the X-ray. Do you see any abnormalities? Don't worry if you don't, because it's a normal chest X-ray. There's nothing in the chest X-ray. So what is the clinical syndrome? So the clinical, like every time you have a case in any branch of clinical medicine, make a clinical diagnosis. Okay. So the clinical diagnosis is prolonged fever in a patient, minimal abdominal symptoms and no localization. And then based upon that, you try to form certain differential diagnosis. Now, can this be a PUO? Now, there is a tendency among all of us to write whatever fever that presents to us, maybe which lasting for like more than 2 weeks or 3 weeks as PUO. Now, PUO cannot be defined that way. PUO has a definite definition. So, the PUO, to be called as PUO, there should be a fever of 101 on at least 2 occasions, more than or equal to. The illness duration should be more than or equal to 3 weeks. And there is no non-immunocompromised state as well. Okay. So this is a classical PUO. And the diagnosis remains uncertain after a thorough history taking, physical examination and the following obligatory investigations. So there are a set of investigations. Previously, they say you have to admit the patient and investigate for a particular duration of the time to call it as PUO. That has changed now because most of our patients are actually evaluated on the OPD basis also. So, IP evaluation is not a must to call it as PUO. So, any patient who has fever more than 101, 2 occasions, and the illness lasting more than 3 weeks and non-immunocompromised, okay, and after history taking physical examination and the following basic test, if you don't have a diagnosis, you call it as PUO. So, that includes ESR, CRP, TCDC, platelet count, hemoglobin, electrolytes, creatinine, total protein, alkaline phosphatase, alanine aminotransferase, aspartate aminotransferase, LDH, creatine kinase, ferritin, anti-nuclear antibodies, rheumatoid factor, serum protein electrophoresis, urine analysis, blood culture, urine culture, chest X-ray, abdominal ultrasound, tuberculosis skill test or interferon gamma release assay. So, these are the minimum amount of investigation that should be done before you call fever as PUO. Now, what do we have? Here the duration of fever is only around 12 days, okay, and we have not done all the investigation. So, you cannot call it as a pyrexia of unknown origin. So, it's a prolonged fever but not a PUO. Now, there is another tendency to call whatever fever that is coming to us without a diagnosis to call it as a tropical fever. Now, don't call tropical fever because any fever that occur in a country like us, okay, so our country is this, so it's mostly in the tropics and part of the rest is in the subtropics. So, whatever fever that is coming in India is a tropical fever. So, that doesn't give us any meaning. So, whenever you write a diagnosis in your case sheet, it should help you to proceed further in terms of investigations and treatment. Writing tropical fever is not going to help because tropical fever can be anything ranging from bacterial infections, viral infections, whatever it may be. So, do not write tropical fever as a diagnosis. You have to write a specific differential diagnosis. Now, what are the possible differential diagnoses in this patient? I would think of the following differential diagnosis. There can be more actually. So, this patient has presented with fever which is prolonged around 12 days duration without any localization and maybe some abdominal symptoms also. Even if abdominal symptoms were not there, any patient who was presenting with fever lasting for more than 1 week in our country, I would think enteric fever as the first differential diagnosis. So, enteric fever, as you all know, is caused by Salmonella typhi, is transmitted fecal-orally through contaminated food, and usually they are present with prolonged fever. Some of the other symptoms can also be there in the form of abdominal symptoms. Abdominal symptoms can be diarrhea or constipation. Sometimes there may not be any abdominal symptoms as well. So, even though it is called as enteric fever, the absence of abdominal symptoms does not rule out enteric fever. There can be sometimes physical examination, you may get a coated tongue, you may get a relative bradycardia as we have seen in this patient, but relative bradycardia can be seen in many other conditions. Relative bradycardia was classically described in yellow fever. It is also described in various other infections like leptospirosis, dengue fever, brucellosis, scrub typhus, etc. So, relative bradycardia alone does not give us an answer, but that's a potential clue. There is a relative bradycardia. Enteric fever, definitely I will keep as one possible diagnosis. Next, I will keep extra-pulmonary tuberculosis, because in India tuberculosis is so common. The patient does not have pulmonary symptoms, the weight loss and night sweats etc. are not mentioned. So, not a very possible diagnosis, but you will have to keep in mind because sometimes tuberculosis can present in all such ways. Okay, it may not have a localizing features also. Sometimes tuberculosis may just have mediastinal lymphadenopathy and there is no peripheral lymph node. The patient may present with pure fever. So, it's all possible. EPTB definitely I will keep and I will do some imaging if I need to, if the initial investigations are negative. Scrub typhus. Now, look at the name of typhus and typhoid. Okay, enteric fever is also called typhoid fever. So, which means that typhoid is looking like typhus. So, typhus can also be a differential, always a differential for enteric fever. So, scrub typhus is the typhus that is seen in our country. It can have prolonged fever lasting up to around 1 to 2 weeks kind of fever can be seen in scrub typhus. Now, scrub typhus usually associated will have severe headache sometimes and myalgias, okay, headache and myalgias. Usually, it's a rickettsial infection, you get a low platelet count, thrombocytopenia. Here the platelet is low normal, okay. Then you have transaminitis, the ALT, AST will also be elevated. And the patients can sometimes develop complications like renal impairment, hepatic dysfunction, jaundice, etc. In any way, I will also keep scrub typhus as a possibility in fever that is like around 1 to 2 weeks duration, especially if the patient have good severe headache and thrombocytopenia and transaminitis. Okay. Now, infectious mononucleosis. Now, infectious mononucleosis, the incidence of infectious mononucleosis in adult population in India is increasing with the increasing sanitation and all. Previously, predominantly it was children who were affected, but when the sanitation and everything increases, there will be shift in the epidemiology. More and more adult cases we are going to see. That is what we are seeing in the clinical practice also. So, IMN is always a differential for a fever that lasts for than 1 week and with even if there is no localizing feature. Usually, like IMN may have symptoms of pharyngitis, they may complaints of throat pain, and on examination you may also see a membrane over the tonsil. And then you have posterior cervical lymph nodes, which is common in infectious mononucleosis. We don't have lymph nodes here, so that is against IMN, but sometimes lymphadenopathy may not be there. Splenomegaly and hepatomegaly can also be seen, but not always. But then in the peripheral smear or in the differential count, you see a lymphocyte predominance. But that is when you suspect. So you have a patient with fever and they have some transaminitis also, which is common in infectious mononucleosis. Plus they have a lymphocyte predominance in the differential count. Here if we see, even if the counts are normal, the lymphocyte percentage only 30%. So that is not something that will favor infectious mononucleosis as a differential diagnosis. So IMN I will keep low in the doubt. Malaria, can it be malaria? Malaria, yeah, it can present with fever associated. There's no Chels and Riger mentioned here, but still, yes, being in northern India, malaria is definitely a possibility. But we have done a rapid malarial test, and the rapid malarial test usually has a good sensitivity to detect malaria. So definitely that one test doesn't rule out always. If you don't get a diagnosis, you may repeat it. You may also do a peripheral smear. But so the rapid test is negative, you will keep it in the lower down in the differential diagnosis. Leptospirosis. Leptospirosis can usually present with fever which lasts around for 1 week if not treated. And in the second week also there can be a small second spike as well. But usually the fever of leptospirosis lasts less than 1 week. The duration goes more than 1 week, you have to keep other differentials. You should also look at the counts also. In leptospirosis, we expect the total count to be elevated. It's a bacterial infection. Thrombocytopenia, platelet should go down. Here it's almost low normal, but you expect a more thrombocytopenia in case of leptospirosis. And if you look at the liver function test, there will be increase in bilirubin. So bilirubin also will be elevated in maybe normal in mild leptospirosis, but usually when a patient presents to a hospital with such a long duration, elevated bilirubin should prompt us to think of leptospirosis. Along with there will be a transaminitis as well. So ALT, AST will be modestly elevated. Okay. So in 100, 300s, 400s, that can differentiate, not about 1000 usually. Bilirubin also may be elevated, and bilirubin elevation can be unconjugated plus conjugated. So conjugated fraction also can be elevated. Both fractions can be elevated in leptospirosis. So usually, so that is something that we have to keep the bilirubin elevation and modest transaminitis and creatinine. So kidney impairment is again typically seen in severe leptospirosis. So whenever you have a fever, maybe lasting for a week or like less than 1 week, and the patient have severe myalgia and they have elevated torque count, low platelet count, a high bilirubin, a high creatinine with elevated transaminitis level, one of the differential that you have to keep is leptospirosis. But here we don't have these features. This patient is clinically well. The fever has become around 12 days. That much duration is unlikely for leptospirosis. Thrombocytopenia has not yet occurred. It's only still a normal platelet count. Creatinine is not elevated. Bilirubin is normal. It's only mild transaminitis. So I won't keep leptospirosis as a possibility here. Can it be dengue? Dengue as salt for leptospirosis, the fever usually lasts for 5 days, at the maximum 7 days. It doesn't go beyond that. It's usually 5 days of illnesses. Now, dengue can present with fever, but again, as told, when you look at the investigations, in dengue fever, what you usually see is a leukopenia. Here there is no leukopenia, and there will be significant thrombocytopenia also. So we don't see thrombocytopenia also. Considering the duration of illness and the lack of leukopenia and lack of thrombocytopenia, I wouldn't consider dengue fever as a differential in this particular patient. So my first differential was enteric fever, extra-pulmonary tuberculosis, scrub typhus, etc. Suspect scrub typhus, always look for an Eschar, which may be seen in around 40% of patients. So whenever such a patient comes, you look the patient thoroughly and in inguinal areas, axillary areas, under it is females, under the breast, earlobes. There are like many areas where the Eschar of scrub typhus were found. So you have to look at all these to exclude a scrub typhus, but absence of an Eschar doesn't exclude scrub typhus, but you should clearly look for that, because the diagnosis becomes so easy. You don't have to do a lot of investigations, just do a serology for the scrub, and if it comes positive, so the cost of the treatment is really like cut down much, so with certain simple physical examination. So the importance of history and physical examination cannot be overemphasized. So enteric fever, so that is what my first differential was. So we have extra-pulmonary TB also, but we'll not be doing every investigation first. So what we can do is that for enteric fever, do a blood culture. Okay. Now the problem with blood culture with enteric fever, it's around 60% only sensitive. Okay, and especially if the patient had received antibiotics, the sensitivity decreases further. This patient has received cefixime for 3 days, which is an active agent against enteric fever. So you don't expect the blood culture to be positive, maybe positive sometimes, and usually blood culture positivity is maximum in the first week of illness. You can also do a bone marrow culture and all, but nobody is going to do it straight away to a bone marrow culture unless we are really stuck. So we don't want a bone marrow culture at this point of time. What you can do is an IgM salmonella, which has IgM salmonella typhi. There are tests like which are called as typhi dot, which detect IgM antibodies against salmonella typhi. The fairly good sensitivity and specificity, around 80% sensitivity and specificity. So which means that not completely accurate. So there can be false positive, false negative. You look at the clinical scenarios and take. And will you do a VIDAL? Now, VIDAL has gone out of favor for most of the clinicians. It is a test which is associated with a lot of problems. Poor sensitivity, poor specificity, very difficult to interpret as well. So, usually I do not do the VIDAL test. So, either blood culture and IgM salmonella typhi, but predominantly even if the blood culture is negative, in India, when a patient of this kind of patient presents, you always suspect enteric fever, and it is also okay to start an empirical treatment and to assess the response to the treatment as well. So again, so that is enteric fever. So these are the investigations which I want first. Now, if these investigations are negative, then also like I would also send an IgM scrub typhus. Okay, if that is also a negative, maybe like extra-pulmonary tuberculosis is also one possibility that I have kept. So I may do a imaging of the CT, a CT scan of the abdomen and thorax, look for extra-pulmonary tuberculosis. And infective endocarditis also need to be kept somewhere in the back of mind. The blood cultures are negative, but I will at least do a transthoracic echo. So this is like stepwise pattern. I don't want to do all of them straight away, but I did the basic investigations. So what happened to our patients? So blood cultures, no growth, it's expected. IgM scrub typhus was negative and IgM salmonella was positive. Now, as I told you, this is not 100% specific, but in the clinical setting that we have, enteric fever seems to be the most likely diagnosis. So you can give a therapeutic trial. There are two options that we have. There is injection ceftriaxone, can be given 2 gram IV OD, or certain textbook also says BD. If the weight is high, definitely it's better to go for a higher dose. Or you can give azithromycin 1 gram OD. Now there is something that we have to be aware of. Defervescence of fever with ceftriaxone will take time, around 5 to 7 days. Even if it's enteric fever, it will take some time. Okay, so the duration of illness is usually around 10 to 14 days for enteric fever. It may take some time for the defervescence, and you may feel that the patient is not responding. But enteric fever treated with ceftriaxone, it will not respond in 1 or 2 days for sure. Slowly the fever will come down, and for completely to the fever to effervescence, it will take around 5 days. So that we have to keep in mind. On the other hand, azithromycin will give you a faster response, like around 2 to 3 days the patient become afebrile. So either of these drugs you can use as a treatment. Here it will also be a therapeutic trial where the patient responds to that. So our patient was given azithromycin 1 gram OD, and in the third day the patient became afebrile, and we continued it for 2 days duration. So that is the made a final diagnosis of Enteric fever for this patient, and we completed. Azithromycin is recommended for 5 days. Azithromycin was given for 5 days, and the treatment was completed. So this is the most common of the Enteric fever, that is the most common of the prolonged fever that will present to you. Blood cultures are extremely important, okay, even if their sensitivity is low, but if it comes positive, it gives us a definite diagnosis. So whenever such patients comes, you set all fevers, you should send 2 sets of blood cultures, okay. 2 sets is aerobic and anaerobic. Each set will be aerobic and anaerobic should be sent, and the volume of blood that you take in each bottle should be 8 to 10 ml. So we always say our cultures are never coming positive, never coming positive. If you are sending inadequate amount of blood, it's never come to be positive, okay. So you have to send 8 to 10 ml, okay, and you have to use an automated blood culture technique also. So that is something that your hospital have to provide, but if you have a good amount of blood and sending, and the automated blood culture facilities available, your blood culture yield is always good. So in that case, in 60% I have told you, you can get the organism, and that makes a definite diagnosis, and you get the drug susceptibility also. So blood culture definitely should be done. I do not prefer Vidal for Enteric fever. You can do an IgM Salmonella typhi test like the typhi dot test. So these are the investigations to be done, and I've mentioned about the treatment as well. So this is one of the prolonged fever that you may come across. Let us see one more. A 56-year-old male patient from Himachal Pradesh presents with fever of 8 days duration. He is a farmer by occupation. His symptoms started as high-grade fever with intense headache and no vomiting. He did not have any history of loose stools, cough or dysuria. His comorbidities included diabetes mellitus, for he was on glimepiride, metformin, systemic hypertension on telmisartan. He consumed a vegetarian diet. There is no alcoholic use. There is no high-risk sexual exposure. On examination, he was conscious and oriented. He was febrile. His temperature was 100. Heart rate 96 per minute. His BP was 150 by 90. Respiratory rate 20. There is no lymphadenopathy, no splenomegaly, no hepatomegaly, normal vesicular breath sounds, no added sounds, no murmurs. Cardiovascular system is normal. There is no neck stiffness. Since the patient has severe headache, meningitis should always be considered. There is no neck stiffness, there is no focal neurological deficits. So look at the investigations. The total count is 11,000, slightly on the upper side, neutrophilic. Platelet count is low, 87,000. Hemoglobin is okay, MCV is okay, hematocrit is okay. ESR is elevated, CRP is elevated, RMT is again negative. Bilirubin is slightly raised, 0.9, direct bilirubin is 0.9. AST, ALT is 126 by 68. So that is transaminitis, it's elevated over there. Blood urea is okay, creatinine is okay. So what are the possibilities that one would keep in mind at this particular point of time? Okay, now the X-ray is also given. X-ray is normal. There is no infiltrates in the chest X-ray, so chest X-ray is also normal. So what are the possible differential diagnoses that you keep in this mind in the patient with 8 days fever? 8 days, as I told you, the differential will remain the same. You will definitely consider Enteric fever as one of the possibilities here also. Usually, as I told, this much degree of a thrombocytopenia is uncommon in Enteric fever. You can get thrombocytopenia in Enteric fever as well, but here it seems to be a bit higher. And the total count elevation, usually in Enteric fever, it is a normal total count unless the patient go into complications like perforation and all. So total count remains high. So I would suspect my Enteric fever as a differential diagnosis will go down here. Bilirubin is mildly elevated, mild transaminitis, both can occur in Enteric fever. That doesn't rule it out. I feel that Enteric fever definitely should be in the differential but low in the line. Malaria, very well possible. Thrombocytopenia can occur, transaminitis, hyperbilirubinemia can occur. A rapid malarial test is ruled out. I would also do a peripheral smear to confirm it. Malaria is possible. IMN, I don't think IMN, it's a neutrophil predominant. Thrombocytopenias can occur in IMN, but not to this extent. So IMN I will keep in the lower in the list. Leptospirosis, definitely possible. Leptospirosis is possible because the patient has 8 days fever. Usually I would start suspecting it's not lepto when it goes beyond 7 days. So it's 8 days, maybe leptos type possibilities there. Counts are high, thrombocytopenia is there, transaminitis is there, bilirubin is slightly raised, but creatinine is normal. Okay, usually leptospirosis may also have an AKI associated with acute kidney injury. Here creatinine seems to be normal, so that is something against. But you can get normal creatinine sometimes. All patients need not develop all the complications also. Dengue fever is unlikely. Dengue fever, like counts are high here, total count is high. So, and neutrophilic. So, usually in dengue fever, you get a leukopenia. Rarely you can get high counts in dengue, but not usual. Other than that, thrombocytopenia, transaminitis can occur, but the duration of illness is predominantly, which I will not consider dengue, like 8 days is something prolonged for dengue, unless dengue goes into a complication called as HLH, hemophagocytosis lymphohistiocytosis. The diagnosis of dengue is unlikely. Scrub typhus, definitely I will consider scrub typhus is associated with prolonged fever more than 1 week. Intense headache can be there, and thrombocytopenia will be there. Transaminitis can be there. Creatinine may or may be elevated. Sometimes AKI can occur. Many times AKI will not be there. So I would definitely consider it's coming from Himachal Pradesh as a farmer. There is exposure to scrub vegetations. So scrub typhus will definitely a possibility. I'll keep scrub here. 1. Scrub typhus is possibility. Malaria is a possibility, but RMT is negative, so I'll take it down in the list. Enteric fever comes second. So that is what my differentials are. So what are the investigations that I would do for this patient is? So I did blood culture because I was suspecting salmonella, it's negative, and IgM salmonella is also negative, but IgM scrub typhus is positive. So actually I didn't see this patient, a resident saw this patient, my resident saw this patient. So I asked the resident to go back and look, okay. So what did he see? Near the nipple. So it's not somewhere you have to take the shirt off the patient and look. Okay, so near the patient's nipple, okay, here what do you see? Okay, it's a Eschar. So this is a Eschar. So a simple physical examination could have avoided many tests. You could have avoided the blood culture, the salmonella, IgM, and could have been, the patient's cost would have been de-escalated much. So Eschar is a very, very important thing in Indian population. Whenever you have a fever that like 7 to 8 days, prolonged fever, whatever the fever duration may be, look for Eschar, especially in this setting where the patient has thrombocytopenia, transaminitis fever. Scrub typhus becomes a major differential diagnosis. So that is very, very, very important. Look for Eschar. So where do we look for Eschar? Looks like Eschar occurs in places that we don't look. That is the problem with Eschar. So in see, this is a male and female. They have this particular study by AP Kuntavara et al. Which was published. So you can see that Eschar predominantly, like 21% of the times they found the Eschar was in the groin area, and genitally in 17.3% of patients. Who looks at this area? So that is a problem with us. So you have to look in these areas, and then axilla. You have to ask the patient to raise his arm and look in there. Only then you will find the Eschar in all the cases. This is very important. Like unless you do it, the patient will go for all sorts of expensive investigations. Now females also, if you look at the females, chest was one of the main area. Especially you also have to look at the under the breast, or sometimes also axilla around 10.9% of cases, and abdomen in 21.4% cases. So these are the areas where the Eschars are predominantly seen. You have to expose the patient completely with her permission and then look for the diagnosis. So that will save a lot for the patient. So a diagnosis of scrub typhus was made. So scrub typhus is a rickettsial disease which is caused by Orientia susugamushi, and it is caused by transmitted by the bite of mites. Okay, the larvae of the mite called as shigas will bite human beings, and these larvae are predominantly seen in scrub vegetation. At the bite side, it forms an Eschar, and the patients usually presents with fever associated with headache, myalgias, etc. Complications like hepatitis, that is mild elevation of transaminitis, can occur. Some patients can develop renal impairment as well. Sometimes they go to severe complications like ARDS can develop, severe hepatitis can develop, myocarditis can develop. Neurological complications like meningitis, encephalitis, polyradiculopathy, etc. are also possible in scrub typhus. So the diagnosis of scrub typhus, you can do an IgM for ELISA for scrub typhus, which is the most accessible test that is available. A direct fluorescent antibody testing is also available, which is more sensitive, but that is not accessible to most of the labs. Now, whenever you are sending a serological test, you should understand that usually it may take around 5 to 7 days for the antibody formation to occur. So, if you are doing it very early in the course of the illness, these tests will be negative. So, wait around 5 to 7 days, or 3 to 7 days before you send a scrub typhus IgM, other IgMs as well. So, that is important. And when you come to the treatment of this particular disease, the treatment is either you can give doxycycline 100 milligrams BD for 7 days, or you can give azithromycin, okay, azithromycin 500 milligrams OD for 5 days. Now, we have detailed discussion on scrub typhus already been done in another session. You can watch this video. This is basically just an approach to prolonged fever. So, we have two cases of prolonged fever that we have discussed. Both of them did not have any localization, but which means that they are not localized to any particular organs. So, that is a time when you suspect these kind of particular illnesses. A thorough history and physical examination sometimes can give you certain clues which can help you to arrive at the diagnosis. So, that's it regarding this session. Thank you.